So, good evening, everyone. So, today we are here. Good evening, everyone. So, today we are here. Today here we are here for episode 2 of breast surgery as a part of our RxDX surgical videos. So, you have had an introduction to how we are planning ahead with our surgical videos and the total course and app that is available to you. And as a part of our program, so we wanted to deal with surgical videos in a bit different way. So we want to deal separate surgeries in 3 steps. That means that will help you in 3 different areas. The first is during your residency as a surgical resident. Second one is during your NEET SS preparation. And third one is we want to make surgical steps videos so that whenever you go for a surgery, either to assist or to do the perform the surgery yourself, you can have a quick recap of all the steps and the tips that we can provide based on our experience and the experience our teachers have shared with us, so that you can use this video as a very quick review before you go and perform or assist the surgery. So that is the reason why we have divided these surgical videos mainly into 2 parts. And today's part is completely, we will cover the basic anatomy that is required for the surgery of modified radical mastectomy. Then we will go through the important steps, and while going through the steps we will give you the tips that are required so that your surgery will be safe. And then we will go through the complications that are important and how to deal with the complications. In the next part, we will deal with all the different types of mastectomies, because if you see the spectrum of mastectomy, we all know that mastectomy started with radical mastectomy of Halsted. And at the present time, whenever you speak about radical mastectomy, we are dealing with carcinoma breast. So as the carcinoma breast treatment has evolved, even the surgery for the carcinoma breast has evolved. So it started as a very locally destructive surgery to eliminate the whole of the cancer cells, to to now we have reached a point where we wanted to keep the surgery as minimal as possible without affecting the survival outcomes of the patients. So we have started with radical mastectomy, through modified radical mastectomy into BCS, and then skin and nipple sparing mastectomies, and presently we are regularly performing robotic mastectomies. So we may wonder, what is the advantage of robotic mastectomy? Robotic mastectomy, we can go through a very small incision in the inframammary fold, remove whole of the breast tissue, and we can put a implant immediately so that the reconstruction will be done immediately. So presently today our topic is to discuss regarding modified radical mastectomy. So here I wanted to highlight one fact, that wherever you have this word radical in oncology, it means one of the two things. The first thing is either you are removing an additional structure. So if you remove additional structure along with the structure that is affected, you call it as radical. Or sometimes you will do additional lymph node dissection. So whenever you have additional structure to remove, we call it as radical mastectomy, radical surgery. For example, again, like in radical mastectomy, we are removing pectoralis major. Or sometimes whenever lymph node dissection is added to the surgery, we call it as radical. For example, when you call something as radical gastrectomy, what is actually happening is you are removing all the lymph node stations that could be affected during the spread of the disease along with the stomach surgery. But sometimes you may do both. For example, whenever you say something called as radical cholecystectomy, what is happening in radical cholecystectomy? Actually, in radical cholecystectomy, you are removing the gallbladder. Along with that, you are removing an additional structure, which is a segmental resection or wedge resection of the liver. Along with that, you are also doing lymph node dissection. So, radical here means either additional removal of the structure or lymph node. So, here what we have modified, in radical mastectomy in MRM, here we are preserving pectoralis major. So, pectoralis major is not removed in modified radical mastectomy. Then we may have a doubt, what are all the structures that are actually being removed in pectoralis in modified radical mastectomy. So here we have to remember, we will remove mainly 4 different structures. One is breast, second one is nipple areola complex, third one is pectoral fascia. So you should be careful. It is not pectoralis muscle, either major or minor, but it is pectoral fascia. And fourth one is, we will always do a axillary dissection. So these are the 4 components of modified radical mastectomy. As we go along the video, we will try to see separately how these structures are removed and what is the extent of the removal and how it will influence our surgery as we go along. So there is a saying that a good surgeon starts his surgery by a good incision, but a very good surgeon starts his surgery by good positioning. So we always forget that a good positioning is important for a good surgery. So in modified MRM, first we'll start with how we will see how to position a patient. So we have to position a patient supine with the ipsilateral arm extended, look, almost to 90 degrees. Here I wanted to add 1 or 2 tips. The first tip that we forget is to put a sandbag or bolster below the scapula, ipsilateral scapula of the patient. By doing this, what is happening? By doing this, the posterior wall of the axilla will be anteriorly shifted, which will help us to completely clear the axilla. So the first tip is to have a bolster or sandbag behind the scapula. And second important tip is to freely drape the arm. So sometimes the arm may not be freely draped. So it may be kept on the arm board with a drape above that. But this freely draping is important because during the surgery, sometimes to have the adequate axillary clearance, we may have to extend, hyperextend or flex the arm. So to do this easily, if you have a free drape, because all the arm is sterile now, we can ask the assistant to either flex or extend the arm in the required way to achieve the adequate clearance. So the second important thing is to have a free draping of the arm. Third one is, most of the times a little bit of head up and little bit of ipsilateral side up will be helpful in achieving a good exposure to both the breast as well as the axilla. So a little bit of tilt of the table will help you to achieve good axillary clearance as well as mastectomy in most of these patients. So once the positioning is done, then the next most important thing is how to plan an incision. So we all know that there are many eponymous incisions that were being used for mastectomy, right from the radical mastectomy of the Halsted, and then modified Halsted incision used by Mayer, and there are many other incisions. But presently, the philosophy behind the incision planning of the breast has changed. Now the breast incision is completely dependent on, first, location of the tumor. So this is the most important factor that decides how to plan our incision. And second one is the location of the scar. The scar may be a core biopsy scar, or sometimes it may be a incision. So sometimes the patient may undergo a lumpectomy outside and they come with an unsightly scar or eccentrically placed scar. So, but it is important to include these scars during our surgery so that we will achieve good oncological clearance. And the third most important thing is the size of the breast. So this is very important to decide the width of the ellipse that we use for the incision. So the size of the breast is also important. Fourth is, are we planning any reconstruction in the same city? So if we are planning interposition of the LD graft either for the skin or the muscle, if you are doing the reconstruction yourself, you have to plan the incision in such a way that it will help your reconstruction. But if you are asking your plastic surgeon to do the reconstruction, it is always important and it's a good idea to discuss the incision prior with the plastic surgeon so that the patient will have the best outcome. So what are the commonly used incisions that we see? The commonly used incision is the Stewart incision, which is a horizontally elliptical incision, which is known as Stewart incision. This is the very commonly used incision. But if the lesion is not in the ellipse, horizontal ellipse, we may modify the incision to include the lesion. So a little bit oblique modification of this incision is known as modified Stewart incision. But when a lesion is present in the upper outer quadrant and when you want to include the lesion in your ellipse, then the incision that we use is called as Orr's incision. So this completely oblique incision is called as Orr's incision. But I wanted to tell few important points. Like whenever you are planning an incision, you have to keep few points in mind. See, what is the lateral extent? Most of the times we know that it is an ellipse, but we don't know what is the exact lateral extent of the incision. So for that, I would like to go about what are the boundaries of our modified radical mastectomy, or what are our boundaries of our breast tissue. So when we see the breast tissue, the extent of the breast tissue is from the clavicle or subclavian muscle. So clavicle or subclavian muscle is the superior extent of our breast tissue. But whenever you are operating, you will not see either clavicle or subclavian muscle. So when you are operating, the landmark that is very useful is second intercostal space. But when you are describing the extent of the breast, how you describe? You describe that it is extending from the clavicle or subclavian muscle to the inframammary fold. Inferiorly it is the inframammary fold, and medially it is the lateral edge of the sternum. So medially it is the, if you see the sternum, medially it is the lateral edge of the sternum, and laterally it is the anterior border of the latissimus dorsi muscle. So whenever I want to get good adequate exposure to these areas, whenever I am doing a good ellipse, I will not go from this end to the other edge. So what will happen when you give a incision from this edge to the other edge? And when you close the incision the suture line will cross the midline. So the suture will medially cross the midline. First thing is the scar will be unsightly, and crossing midline is not, they will not give any good cosmetic results. Second thing is laterally it will go into the axilla, and whenever it is going into the axilla, then the another problem is most of the times when these patients require post-operative radiotherapy, we have to include the scar in radiotherapy. So when the scar is going into the axilla, so we have to give radiotherapy to axilla. And we all know that when we have an adequate axillary dissection, most of the times we will not radiate the axilla, because when there is surgery as well as the radiation, so surgery plus radiation to axilla is equal to more lymphedema. So our aim is to decrease the chances of lymphedema. So usually we will not give radiation to the axilla. But when your incision length is complete, when it is going into the axilla, we have to radiate the axilla, which is not good for the patient. And medially also, when it crosses the midline, it is not good cosmetically, and also it will increase the radiation field. So that is the reason why when you are practically planning the incision, it's always good to leave at least 2 finger breadths away from the your lateral end, medial end, and 2 finger breadths away from your anterior axillary fold. So when you leave these 2 finger breadths incision, when you close the incision, it will exactly come to the lateral end of the sternum as well as the anterior axillary fold, so that there will not be any problem. Second important thing is how to determine the ellipse of the incision. Most of the times we know that it is the elliptical incision, but how do I know if I have to take this much, or if I have to take this much, or if I have to take this much? So we'll see what is the problem when you take a bigger incision. When you take a bigger incision and when you try to close, then the tension across the suture line will be higher. So when there are tension across the suture line is higher, either it will cause wound dehiscence. So either it will cause wound dehiscence or skin necrosis, or if these two things doesn't happen, at least it will cause unsightly scar. So one of the reasons for bad scar is excessive tension across the suture line. So that is the reason why you have to plan your ellipse in such a way that when you close the wound, it should snugly fit the chest. So there will not be any excessive tension and there will not be any excessive tissue. So what will happen when the ellipse is smaller? It will cause two problems. The first problem is because there will be good amount of dead space, it will increase the chances of seroma. Second thing, whenever there is excessive skin, whenever there is loose skin, this loose skin densely adheres to the chest wall, and it will again form the very bad scar. So it is important both to plan your length of the incision as well as width of the incision. This is very important. And again, your incision should be planned in such a way that it will give you a very good access to the axilla. If your incision is too small, your access to the axilla will be very difficult, and you have to retract the skin flaps a lot, which will again influence the health of the skin flaps, which will cause flap necrosis. So then after the positioning, and when you have decided and when you have chosen the correct incision of correct length and correct width, the next most important aspect is raising the flaps. This is the second step in doing a good modified radical mastectomy. So how do you raise the flaps? The most important thing is how to identify the plane. So most of the times when you see the textbooks, they say that the breast flat globules are larger. So the flat globules in the breast are larger compared to the subcutaneous fat, which is lighter and smaller. So our aim is theoretically to go and identify a plane between the smaller flat globules of the skin, separate it from the larger fat globules of the breast tissue. So your aim is to get an optimal thickness of the skin flap. Optimal thickness is our aim. So what will happen if it is thin? If it is thin, it will cause necrosis. If it is thick, what will happen? If it is thick, it will lead to residual breast tissue, which will influence the oncological outcomes of these patients. So practically, how you see this? Practically, the best way to identify this plane and to have a very good thickness is to understand the anatomical relationships of the breast tissue with the subcutaneous tissue. So the ideal skin thickness is the one where the subdermal blood vessels will be taken onto the skin flap, not into the breast tissue. So if you are seeing excessive blood loss while doing a mastectomy, so you should understand that when you are having blood loss, your plane is not good. Our aim is to keep the subdermal lymphatics into the skin flap so that the blood supply to the skin is good and the survival chances of the skin is better. And the second most important point that we forget is the angle with which we enter the we try to do the surgery. So how do we do surgery in mastectomy? Either we can use a blade, that is scalpel, or some people do with scissors, or we can use cautery, that is electrocautery. Most commonly oncology people and most of the surgical oncologists, we use cautery. So previously there used to be a myth saying that when you do cautery very close to the skin, the chance of necrosis are higher. But now we have a very good evidence saying that you can use electrocautery raising these flaps. But the important thing is how you go ahead with the angle with which you do the dissection is also very important. So imagine you are asking your assistant to do so how you have made the incision, and then you use skin hooks to lift the flap, and when you ask the assistant to do assistant to lift the flaps, they will over enthusiastically they will stretch the skin excessively into towards them. So how the skin will be? The skin will be excessively lifted towards them. So this is the skin hook. So when you are doing the flap, when your cautery comes in a perpendicular plane to the raised flap, the chances of damage to the skin and buttonholing are very important. So one tip here is to ask your assistant to lift this perpendicularly up. Imagine this is the skin surface and this is the hook with which they are lifting the skin flap, and you try to keep this angle perpendicular. And now when you are doing your surgery, your left hand is very important. You are giving a very good traction with your left hand on the breast tissue, and then your cautery is relatively parallel to the skin flap. So when you do surgery in this way, the chances of buttonholing are very minimal. And again, it's important to check your thickness, and you can ask your assistant to see whether the skin thickness is thinner or if the skin thickness is thicker. But the most important thing is your angle with which you do the surgery is also important, and the angle with which the assistant pulls the skin flaps is also important. So that is one thing. And the second thing is, again, most of the times you can see the difference in the size of the skin globules. But you should have caution, especially when you are doing surgery in particular set of the patients. In which patients you should be careful. One, when you are dealing with the diabetic patients, always try to have a thicker flap compared to the other people, because the chance of necrosis are higher. And second one is, especially in smokers, even the flap thickness should be thicker. And the third most important subset are septa and octogenarians. That means the people who are in 70s and 80s. So we are regularly doing surgeries now in people who are in 80s, but we should be very careful because the subcutaneous fat will easily peel off from the skin because of their age related uh, loosening of the skin. So in diabetic smokers and these people, we should be very careful while dealing with the skin flaps. That we will try to keep the skin flap thick in these patients. So once we raise the skin flaps, so here again, till where we will raise the skin flaps? Inferiorly, we have to raise till the inframammary fold, and superiorly it is till the clavicle, and medially it is the lateral edge of the sternum, and laterally it is the LD pedicle. And while lifting from the pectoralis major, we have to always include the pectoral fascia. Why we have to include pectoral fascia? In oncology, we have to remember an important fact that any fascia, it acts as a natural barrier for against dissemination of these cancer cells. So whenever you include any fascia as a margin in both carcinomas, which are epithelial cancers, or sarcomas, which are mesenchymal cancers, they will give us a very good oncological safety because they are relatively resistant to the spread of the cancer cells. So it's always important to include pectoral fascia as a base. When you are lifting the breast tissue away from the pectoralis major muscle. And again here it is important, once you lift the breast tissue from the pectoral muscles, it is important to palpate for the base of the tumor. If the base of the tumor is very close, we may have to sometimes remove a small area of pectoralis major muscle along with the our mastectomy specimen, so that our oncological margins are very clear. So this is the so we will gradually lift the breast tissue away from the pectoralis major along with the fascia from medial to lateral part till we see the lateral end of the pectoralis major. Here is the part where we are entering into the axilla. So we will go into the dissection of the axilla. But here you can either complete the upper flap and lower flap, then gradually lift the breast off the chest wall to enter the axilla, or sometimes people either they will lift the only upper flap and then go to the axilla, clear the axilla and complete the lower flap. And you can do it in any of the both the ways. And again, there is one more way of dealing with the skin flaps, that is hydrodissection. Some people use either ringer lactate or lignocaine with epinephrine injection into the tissues in between the both the fats, and they will try to identify the plane during the hydrodissection. But most commonly, this is not a very commonly used method, and it is a cumbersome method. If you have a very good traction, counter traction, you can achieve a good oncological clearance and clearance of the breast tissue without having any damage to the skin. So then coming to the axilla, the axillary clearance is again a very important part of our surgery. So modified radical mastectomy always includes axillary clearance. So before going to the axilla, we can grossly divide the lymph node stations that are in the axilla into level 1, level 2, level 3. We all know that they are divided into level 1, level 2, level 3, but it is based on the one muscle, which is a smaller muscle, which is the accompanying muscle of the pectoralis major, which is known as pectoralis minor. So based on their relationship, lymph nodal relationship to this pectoralis minor, when they are medially present, they are called as level 3. When they are laterally present, it is level 1. And when they are present behind the pectoralis minor, it is called as level 2. And there is one more group of lymph nodes which are called as Rotter's lymph nodes. Rotter's lymph nodes, which is sometimes considered as a part of level 2, which are also known as interpectoral lymph nodes. But once you enter the axilla after completing the breast part of the surgery, the most important step is to retract the pectoral muscles. So one more important muscle that we have to keep in mind while studying or discussing about pectoral modified radical mastectomy is pectoralis minor muscle, because based on how you deal with pectoralis minor muscle, historically the modified radical mastectomy is divided into three types. So when you completely resect the pectoralis minor muscle, it is called as Patty's variation of modified radical mastectomy. But when you just retract without cutting or without resecting, then it is called as Auchincloss type of modified radical mastectomy. In Auchincloss, which is the most commonly used type of modified radical mastectomy at present day, you will ask your assistant to retract the pectoralis minor muscle. But the advantage of and when you cut and resuture it after cut and resuture after the procedure is done, it is called as cannula. So previously people used to say that in both patties as well as in cannula, we can resect level 1, level 2 and level 3. But with cautious surgery, with extra care, we can even remove level 1, level 2, level 3 even with Auchincloss. So there are methods with which you can remove all the tissue which is above the pectoralis minor muscle along with the other lymph nodal stations while doing the surgery. So these are the three types of modified radical mastectomy based on how you deal with pectoralis minor muscle. So next, what are the boundaries of the axillary lymph node dissection? This is a very important topic, and even from the surgical surgery point of view as well as from the NEET SS point of view, there are many questions that can be asked based on the boundaries, the extent and the complications associated with the axillary lymph node dissection. So first we will see what are the boundaries of the axillary lymph node dissection. The medial boundary is nothing but the long thoracic nerve. Medial boundary is long thoracic nerve, or it is also called as Bell's nerve or Naruto serratus anterior. So this is our medial boundary of our axillary lymph node dissection, and superiorly it is the axillary vessels. So that is the axillary vein and the axillary artery, axillary vessels, and the upper extent is nothing but Halsted ligament. Also known as costoclavicular ligament. And laterally it is the thoracodorsal pedicle, which includes the thoracodorsal nerve, thoracodorsal vein and thoracodorsal artery. And inferiorly it is the angular vein or chest wall branch of the vein. So in axillary lymph node dissection, we have to completely clear the area between these boundaries. So this is the area of the axillary lymph node dissection. So here one more thing that we have to identify and see are there are 3 or more intercostal nerves that are seen in the axillary, in this area of axillary dissection. And the second intercostal nerve is called intercostal brachial nerve, and usually it is advised not to go above the upper intercostal nerve, so that you will not remove the lymph nodes that are coming from the upper limb, and also it will decrease the chances of lymphedema in this patient. So when there are 3 or 4 intercostal brachial nerve, don't dissect the fibrofatty tissue that is above the upper intercostal nerve, so that you will decrease the chance of lymph node dissection. And again, if someone asks you what is the most common nerve that is injured during the axillary lymph node dissection, that is the intercostal brachial nerve. And what will happen when there is injury to the intercostal brachial nerve? It will cause paresthesias of the medial aspect of the arm. So whenever the patient wears any blouse or any dress, so she will have paresthesias or discomfort at the level of the arm. So it doesn't have any motor function, but sensory. If you can preserve intercostal brachial nerve without affecting the oncological clearance, you should always try to preserve the ICBN nerve. So, and next, what else can happen? So here I wanted to tell you one more important aspect. So how will you identify axillary vein? How can you go to that upper extent without having any problem? One most important landmark that we regularly use is the median pectoral pedicule. So what we call median, we usually say median pectoral pedicule as the loop. So whenever you have lifted the breast tissue and when you just enter the axilla, when you just incise the clavipectoral fascia along the lateral end of the pectoralis major, you will see this loop. So whenever you see this loop, you should understand that within 1 centimeter of this loop, within 1 centimeter, you will encounter axillary vein. So this is very important landmark in the axilla, so that you will not damage any axillary vein. That is the first thing. And second important thing is, whenever you see that loop, you will get the intercostal brachial nerve a bit lower than this in relation to this median pectoral loop. So another 2 nerves that are associated with axillary dissection are, one is the median pectoral nerve, which is medial pectoral, which is laterally seen, but it is called medial pectoral because it originates from the medial cord. And second one is the lateral pectoral nerves. So these two are nerves again you encounter while doing the lymph node dissection. And again, you have to be careful while dissecting the thoracodorsal pedicule, because if the patient requires a latissimus dorsi flap now or in the future, it is very important to preserve this thoracodorsal pedicule while doing the lymph node dissection. But another important aspect that we have to remember is, if you see any enlarged lymph nodes away from this or very close to these boundaries, we have to remove them. We should not leave any suspicious enlarged lymph node when they are just outside this axillary dissection. And again, the other nerves that can be injured while doing this axillary dissection are, again, there could be injury to the Bell's nerve, which will cause winged scapula. So it will cause winging of scapula. And there could be injury to the thoracodorsal nerve, which will have effect on adduction, internal rotation, and extension of the arm. This is because of the injury to the LD innervation to the LD pedicule. So again, so once we have completely cleared level 1, level 2 and level 3, how will we know that our axillary dissection is adequate? So is there any criteria to know if our axillary dissection is adequate? So usually we take as 10 lymph nodes. If the pathological specimen contains at least 10 lymph nodes, we can consider that the dissection is adequate. It's not like we will remove only 10 lymph nodes. So this is for the staging purposes. If you see a pathological specimen where the lymph nodes are less than 10 in number, then you may consider that is as an inadequate surgery. And sometimes you can prescribe additional adjuvant treatment to compensate this inadequate surgery. And along with that, what are the other complications that can happen? The injury to the axillary vein. When you clearly identify and protect it, it is an uncommon complication of the axillary dissection. And any any injury to the excessive traction can cause skin necrosis. So once you have completed your mastectomy, once you have completed your axillary dissection, the most other important factor is closure. As I have told you, while you are closing, you have to remember two things. One, the tension should be minimal. Two, it should not be either crossing midline or it should not go too much into axilla. And three, the drain should be placed in such a way that it will be close to the surgical side but not very close, so that even the drain side can be included while giving the radiotherapy. So usually the drain is placed along the lateral part of the incision, 1 inch away from the edge of the skin, so that it can be easily included into the radiation field. So what is the drain that we use? We use a vacuum drain, which is usually called as Romovac drain. And second one is usually we will use drain with two limbs. So one limb is kept below the mastectomy flap, the other limb is kept into the axilla, and the suction is applied. And when will you remove the drain? So few textbooks, I think Bailey and Love, they say it can be removed any day, anywhere after 5th day. But most commonly used method is when the drain output is less than 30 ml. So usually then we will remove the drain. So when it is less than 30 ml, the seroma that is formed can be absorbed into the body. That is the general level that we remove the drain after. So what are the complications of the mastectomy? The most important and most common complication of the mastectomy is seroma formation. So is there any way to prevent this complication? So as I have told you, when the skin flaps are snugly fitting, then the dead space will decrease and it will cause decrease in the chances of the seroma formation. And second most important thing is, there are studies which say that whenever you use any energy devices like ligashore or harmonic while doing the axillary dissection, then there will be a chance that because we use this ligashore and harmonic or energy device to seal the lymphatics, there is a relatively less chances of seroma formation after the surgery. So usage of the energy devices may also decrease the chances of seroma formation. And the third one is appropriate removal of the drains. So if you remove the drains too early, then also there are chances of seroma formation. The other most common complications associated with mastectomy are skin complications like skin necrosis, that is flap necrosis, or flap infection. Again, by good technique and by avoiding excessive traction on the skin flaps, we can decrease the necrosis of the flap or flap infection. Now we have multiple methods. So now we regularly use indocyanine green before completing the surgery. So by injecting the indocyanine green, we can check the vascularity of the skin flaps, and if there is any decreased vascularity, we can revise the skin flap. By doing this, we can decrease the skin flap necrosis. So these are the important aspects that we have to look forward when we are doing a modified radical mastectomy. Thank you.